Oh, good morning, Akash.
Good morning.
Dr. Mishra, I should say. How are you doing?
Fantastic. How are you?
I'm good, thank you. Thank you so much for joining us. I'm Hannah, and
I'm
this is
Quinn.
Quinn. She's my co-planner colleague who's helping facilitate the BRAINterns program along with Dr. D'Amico. We just want to thank you again for joining us this morning.
No
Yes,
problem.
thank you. Everyone's joining in again. Welcome, everyone.
Welcome back, everybody. I'm posting a link to the PDF of the schedule. So a lot of you have been requesting the schedule. We have it in a link in the PDF. You also go to the following URL on our BRAINterns website. You will be able to access the schedule on our BRAINterns website as well. So I'm going to send that to you. And then, Dr. Mishra, do you have any PowerPoint presentation that you would like to use?
I do. Do I have access to the share?
You should. Let's try. Yep. You should be able to share. Perfect. Amazing. So we still have about 4 minutes before we start, but looks like everything's working tech-wise on your end. And then all right.
And a few more housekeeping things, just like this morning. You may use the chat in a positive way, but if you have any questions, please use the Q&A so we can answer your questions directly. And then I also posted the Facebook link in the chat, and I'm just updating on Facebook and Slack. I will also post the Slack link in the chat. And it's so nice to see everyone again.
The Otter AI. What is the Otter AI? What is that? Nice to see you guys too. I see. Are you talking about the YouTube link? I see. Okay. You guys are much more techie than I am, so I appreciate your advice. Also, I apologize that earlier I was just a black screen. I had a quite an interesting commute. It was a very New York City morning. Somebody got hit by a train, and the 6 trains were messed up in both directions. Moral of the story, if you ever come to New York City, do not stand close to the platform. It is extremely dangerous. That is what this passenger was doing. And unfortunately, they were hit by the train. I don't know the status of this person's condition. But again, if you're ever in New York, please, please, please stand far away from the platform edge. It's there's a reason there's a big yellow line, because it is dangerous to stand that close. That's my PSA for the day. As much as we'd love to see you at Lenox Hill Hospital, we don't want to see you as a patient. So. All right. We're going to get started right now. It's 10 o'clock a.m. Thank you all for joining us again. Welcome to the BRAINterns webinar series. This morning, we are going to be speaking with Dr. Akash Mishra. He is from the Zucker School of Medicine, and he's going to talk about clinical neuroanatomy of the spine. And this is a great introduction for those of you who are interested in pursuing a career in neurosurgery and focusing on the spine. This is a great introduction for med school. So I just want to thank you again, Dr. Mishra, for joining us and volunteering your time. We so appreciate you, and we can't wait to hear from you.
Yeah, no problem. And thank you for having me. I think this is a wonderful opportunity, especially to learn and get some insight as to what the brain is like, and just delve right in. And it's a fantastic group of speakers that you have in the lineup, and I guess we can start the week off with some anatomy of the spine. So thank you. So my name is Akash Mishra. I'm a third year MD PhD student. So I just started my PhD phase after my 2 years of medical school. I'll be talking a little bit about the spine. I'm going to try to make this as interactive and case-based as possible. I think that just makes it a lot more interesting. And regarding questions, I'll take questions at any time, either in the chat or the Q&A, but if I don't get to it immediately, it's not because I'm ignoring you, it's because I probably didn't see it. I'll have a few minutes at the end built in for any questions as well, and then I'll also stick around to answer other questions in the Q&A afterwards in case I don't get to everything. So, earlier in the earlier session, I think we had the chat function working. I'm going to try to use the chat functionality throughout this talk. Let's get that warmed up. Where is everyone from, and what level of school is everyone? You can just drop your answer in the chat. New York. United Kingdom, Toronto. Oh, wow. Bunch of pre-meds, a lot of people in high school. It's fantastic. And it sounds like we have a lot of countries from around the world. So thank you for tuning in. I know it's probably not morning everywhere. And I think there's probably some people tuning in probably late at night or very early in the morning. So thank you for that. All right, so I think we can get started. So it's my solid belief that you should always know why you're studying something before you learn about it. So to start, I'm going to try to convince you why the spine is important and why it needs to be studied. So let's start with a question. What are some key functions of the spine? Why is it important? And once again, you could drop your answers in the chat and I'll read some of them off. Stability, posture, support, mobility, all of these are exactly the right idea. Signal transmission, I like that one. Movement, protecting the spinal cord, nerve function, wonderful. So that's exactly what I was thinking as well. So I've kind of boiled it down here to 5 key reasons, but there are several others as well. So first, it protects the spinal cord, which is kind of like the highway of connections between the brain and the body. It carries the weight of the body. Approximately 50% of your body weight and your axial load is carried by the spine. It's a major site for hematopoiesis. So essentially the formation and generation of red blood cells. It organizes with several other bones of the axial skeleton, such as the ilium of the pelvis and the ribs, and we'll get into that a little more detail in a couple slides. And the 5th one, it allows for some structural stability while also allowing for gross movement. So it's a structure that's unique because it's very strong and has a lot of structural integrity, but it also has a ton of flexibility, which is needed for our movement and even day-to-day action. Okay, so the spine does a lot for our function and allows for our day-to-day living, but as healthcare providers specifically, why else should we study it? Well, there are several very common pathologies associated with the spine, and here we can start with a case. We have a 17-year-old female comes in your office with a 1-year history of worsening pain in the mid-thoracic region. The pain is absent at rest, but worsened by playing sports. And in this case, this female patient loved playing soccer. So she's unhappy that her shoulders are not symmetrical. What is on your differential diagnosis? So I see that a bunch of you jumped in scoliosis. I'm going to try to push you. Is there anything else that this might be? I see kyphosis, lordosis. Okay. Muscle-related issue. So that's an interesting one. I think that anytime you have worsening pain in the mid-thoracic region, yeah, it could always be a muscle issue. It wouldn't necessarily make her shoulders asymmetrical, but it's a good point, and it's always something that you have to kind of keep in mind. Okay, so let's say this is scoliosis. How can we treat this patient? I see PT, surgery, a back brace. Wonderful, wonderful, fantastic. So those are 3 kind of key modalities here as to how this patient can be treated for scoliosis. And here on the right, I have added a image. In this case, this is an X-ray. The head is towards the top of the image here. And the legs are towards the bottom, and you can see kind of the spinal column doing following a curvature. It's supposed to be straight up and down, ideally. So in this case, the degree of the curvature of the spine supported a clinical, I guess, thinking that supported surgical correction. So this patient underwent a spinal fusion. And here we have the side-by-side of the pre-operative as well as post-operative after the scoliosis correction surgery. And after 12 months, the patient reported no pain at rest or exercise, only some mild stiffness in the lower back. The patient returned to playing a high level of soccer and reported much improved alignment of the shoulders. So overall, the patient did absolutely fantastic. So the reason I picked this case is because scoliosis affects almost 2 to 3% of individuals worldwide, and that's a remarkable number. Treatment options, as you guys in the chat pointed out, include PT, a brace, or surgical correction, and even within surgical correction, surgery, there are many options of how to do that. And patients can be treated from a very young age, not necessarily teenage and above, but also as young as 10 years old. I've seen a couple of cases. So this was all to say, the spine has a bunch of functionality and pathology, and the pathology in some cases can be quite clinically severe. Here are just a bunch of other pathologies of the spine that millions of people worldwide suffer from. I've listed some of the most common ones, including tumors, spinal stenosis, herniated discs, arthritis, scoliosis, vertebral fractures, and there's many, many more. So at this point, hopefully I've convinced you to kind of stay on and learn a little bit more about spine and why it's important. Although I don't know if that was necessary for this group, considering a lot of you guys seem like you're experts already. So let's begin. A key clinical mainstay of medicine is A, the physical examination, but B, imaging, and learning how anatomy looks like through different imaging modalities. In all cases, I don't think there's a scenario where this is not correct. Imaging should always be complementary to a comprehensive history as well as a physical exam. So they're kind of paired. You should try to never do imaging without a physical exam, and if the physical exam warrants imaging, I'll always try to get the imaging, but also the correct imaging modality. So I have here 3 lateral images of the spine. In each case, the patient is facing towards the left of the screen. The head is at the top, the legs are towards the bottom, and the legs are cut off at about the level of the sacral or spinal cord or the coccyx. And there's no gross deformity in each patient. You can see that the spinal cord is aligned, it's straight, it has the curvatures that are physiologically warranted and correct. And you can see that the spinal cord is also not occluded or damaged in any way, shape, or form. So I want us to try to match the imaging modality with the image. So let's start with image A here. Out of these three modalities, the X-ray, the T1 MRI, and the T2 MRI, which modality is this? And you could drop your answers in the chat. I see a lot of T2s, some T1s, some X-rays. I think most people think that this is T1. Okay, so why do you think this is T1 or T2? Color, okay, I see CSF color. And that's kind of what I'm going for. T2 shows water, fluid. Wonderful. Okay, so I think I see some answers that are kind of what I'm trying to get at here. So this is a T2 MRI, and T2 simply means the weighting of the image, how the different tissues are colored. Are they light or are they dark? And in this case, you can see within the spinal canal, there's fluid, and this fluid is CSF, and the CSF appears to be bright. So that's kind of the key giveaway, that you're looking at a T2 image instead of a T1 image. The CSF is going to be bright. Now, if we hop over to C, what do you think this modality is? T1, wonderful. And we know this because, especially if you compare with the T2, the CSF within the spinal canal is dark, it's not bright at all. So that means this must be a T1 image. Now, as you go through your training, you'll see many, many more of these. So don't panic if you didn't recognize that immediately, but that's kind of like the general rule of thumb of how you could tell T1 versus T2. There's several other ways. You can look at like bone density, fat density, so on and so forth. But that's the clear cut, I think, easiest way and the way that I learned it. Okay, so if A is T2, C is T1, that leaves B to be the X-ray. Can anybody try to tell me why this is an X-ray, or what characteristics of the X-ray imaging modality cause the image to look slightly different? Shadows, absolutely wonderful. It's foggy, that's true as well. So X-ray overall is a cheaper modality that is quicker to attain and easier to access, but the image itself is less sharp because of all the shadows that are in front of it. So you could see all these visceral organs and other body structures, like here's the arm, kind of covering the rest of the anatomy that's underneath, but you could still see the spinal cord. It still serves to give you a good image. Okay, so we can move on, and I see people asking which one is T1 again. I think these slides will be shared. If not, we could have them shared. I have all the answers and explanations in the comment section of the slides, so you could feel free to go back and reread if you missed something. Okay, so let's shift over to the bony anatomy of the spine. Here's an illustration of the spine if you laid it on a flat surface. The head or the skull would be at the top, the legs would be down below. And you could go ahead and count, but let's see, does anybody know how many vertebrae or bones there are in total and what the 4 divisions are? 34, 33, 31. Wonderful. 31 to 34. And somebody put the 4 divisions. There are technically 5, I guess. I probably should have asked 5, but wonderful. Okay. So there are 5 divisions of the spine. There's the cervical, the thoracic, the lumbar, sacrum, and coccyx. And each one of them have a specific number of bones or vertebral bodies. The cervical has 7, thoracic has 12, lumbar has 5, sacrum has 5, and the coccyx has 3 to 5. I said 3. So depending on the number that you pick, you could end up with anywhere between 33 and 35, I believe. The reason why the number kind of varies is because the sacrum and the coccyx are both fused. So if we look at the bottom here, there are 5 of these individual bones, but they ended up being fused during embryonic development. And that's why those are kind of separate from the rest of the vertebrae, which are separate and spaced out. Okay, and I guess to kind of close the loop here, to name them, we can name them by assigning the number of the vertebrae that's in that division. So the first cervical vertebrae would be C1, then under it would be C2, C3, C4, and so on and so forth. So to name them, we could say like C5, L3, T10, so on and so forth. Okay, so I said that there are 7 cervical vertebrae, but I see a C8 here. C8 dorsal root ganglion, cervical goes to C8. Why is this? If anybody knows, you drop your answers in the chat. No idea. That's all right. Oh, we said nerve roots. Okay, spinal nerves. Wonderful. So this image on the left also is counting the nerve roots. So when we're counting the nerve roots and the vertebrae, they each are counted the similar way, so such as C1, C2, C3, so on and so forth. And the nerve roots also have their own very similar naming convention, C1, C2, C3, so on and so forth. The interesting thing is that C1 to C7, the nerve roots will exit on top of the respective vertebrae, so superior to the respective vertebrae. And from C8 below, it switches to below, so exiting inferior to the bone. So that's why there's a C8 nerve root, but there's no C8 vertebrae. And we'll come back to this idea in a little bit. And the last thing I kind of want to point out here is you see the vertebrae and there's a spinal cord within the vertebral canal here. And the spinal cord itself exits at about T1. Let me see if I have a better picture of this. I do. It exits, it ends at about the L1 vertebral level. So this is called the conus medullaris. This is where the spinal cord, quote unquote, ends. But the nerve roots continue down to where they need to go, especially the sacral spinal cord. So this is called the conus medullaris, where the spinal cord ends. And below it, all of these nerve roots that are continuing to run in the spinal canal to the respective or target vertebral bodies, this is called the cauda equina. Cauda equina, loosely translating, I think in Latin to horse's tail. So this has some implications for when you take a lumbar puncture, for example, you want to take it down here rather than where the spinal cord is. So you'd usually take it around L3 to L4. And epidurals also take advantage of this and so on and so forth. But it's a neat characteristic and one that's pretty interesting. All right. So let's move on to the structure of the individual vertebrae. So this is one vertebrae and they have it colored. They have it colored so that the vertebral body is in red and the rest of it is called the vertebral arch, and that's in blue. The image on the right kind of splits this further. So the orange are the pedicles. The blue and purple are the superior and inferior articular processes. The pink are the transverse processes, and the green here is the spinous process. I'm sorry. So you can see that there are two kind of key components to axial loading or weight going up and down. One of them is the vertebral body itself, which this is a lateral image or cartoon depiction of each individual vertebral body and how it interacts with the one inferior and superior to it. So the vertebral bodies themselves are separated by this disc, which allows it to interface with the vertebral body on top of it. But there's also these superior and inferior articular processes that allow it or allow for some additional support and play a large role in maintaining vertical load and balance. And essentially both of these components are critical for, I guess, axial loading. So just to make sure that we're all oriented, if you were to go to a patient and palpate deeply at the midline, what part of the vertebrae would you be palpating or feeling? Perfect. The spinous process, because this is the most dorsal. Wonderful. So this is dorsal or posterior. This is ventral or anterior. And we see this hole here in the middle with this nice star indicating that's the vertebral foramen. What goes in here? It's the hole for the spinal cord. Wonderful. So I think I have a better picture of that at some point. So we'll come back to that in a little bit. So the nice thing is, well, nice or not nice, depending on how you look at it, is that at each section of the spine, the vertebral bodies have a different appearance. So here I have 4 sets of vertebrae, each one corresponding, or each color corresponding to a different section. And we're going to match them and try to explain why they look different based on where they are. So let's start with the cervical spine. Which color would this be associated with? We see some red, blue, a lot of red, some blue, now more blue. Okay. So why is it blue and not red? See some transverse processes. So actually all of them, the thoracic, lumbar, and cervical all have transverse processes. Transverse foramen, wonderful. So if you look at this cartoon here in the blue, there are these 2 holes, one on each side of the vertebral body that are labeled as the transverse foramen. Now this is pretty important. Does anybody know why? The vertebral arteries. Wonderful. So this is where the vertebral arteries pass through. And I know you guys have a lecture on the skull and the brain coming up, so you'll probably delve a little further into this at that point. But these are where the vertebral arteries that are supplying the brain, or partially supplying the brain, I should say, are going up. And this only exists in the cervical spine. It is not a feature of any other spinal process or vertebral body. So that's a pretty good way of figuring out that this is the cervical spine. So let's move over to the thoracic spine. Which color corresponds to the thoracic spine? Okay, wonderful. I see a lot of red. And can anyone give a justification of why it's red? Costal facets. Okay, that's exactly what I was going for. And the body is not so massive, but still large. Great. So a key giveaway here is that the costal facets are here, which is also denoted as number 3 on here and labeled as the transverse costal facet. This is the interface between the vertebral body and the rib that it attaches to it. So we talked about how the spine interfaces with a lot of other structures. This part of the spine interfaces with the rib, and the rib bone attaches right here where number 3 is. And this is a property that's unique to the thoracic vertebrae. And I think somebody else mentioned that the vertebral body height is also not as large. That's correct. I would agree with that. But also the cervical spine vertebral body is also not very bulky either. So that's a way to determine that it could be thoracic, but the costal facets especially, as well as this kind of sloped or vertically oriented spinous process, that's another kind of giveaway that you're looking at a thoracic vertebrae. Okay, so so let's move on to lumbar. Which color is associated with lumbar? Green. Green, we have a lot of green. And I'll just give you this one. The lumbar vertebrae has very bulky vertebral bodies, and the spinous process is also kind of truncated. It's short, so it's much shorter than the cervical spine. It's much shorter than the thoracic spine. So if you have a bulky vertebral body with a very short spinous process, it's very likely you're looking at a lumbar vertebrae. Now, finally, that leaves sacral with purple. And what's kind of the giveaway that you're looking at the sacral vertebrae? It's fused. Wonderful. Yeah, and we touched upon this a little bit. It's fused. There's 5 fused vertebrae that look like a singular structure. So here's it from the lateral view. Here's it from, I guess, the superior anterior view, and this is the posterior view. And it interfaces directly with the coccyx. Okay, so let's keep moving. I think somebody mentioned atlas and axis very briefly. I'm going to take a very quick aside to talk about that. So here are the 7 cervical vertebrae aligned from C1 to C7. And the C1 and the C2 vertebrae are shaped a little bit differently due to the proximity to the skull. So the C1 is known as the atlas, and the C2 is also known as the axis. They articulate very closely with one another through this process called the dens. It's also known as the odontoid process. And this is located on C2. It kind of interfaces or interlocks with the C1 that's on top of it. So on imaging, since these two are very close together, and the skull itself sits right on top of this, we look for this kind of triangle, and we call that the C1, C2. So essentially what that means for our imaging is that we look at this first one, and we're going to call it C2, the next one C3, C4, so on and so forth, and then we could count down from there to figure out where the pathology is. So essentially we look for this kind of triangular structure, and then call that both C1 and C2. Okay, so let's now add some soft tissue and nerves to the story. Here on the left is a picture of the vertebral column running through the spinal cord, and this is kind of a posterior lateral view, kind of like an oblique view. And you can see all the spinous processes coming out back. So that's how you know we're looking at this from the posterior. The spinal cord is running through the longitudinal vertebral foramen all the way through, and that goes all the way up to the brain, all the way down until the caudoclina and the sacral spinal cord. And once again, kind of touching upon that, if I tell you that, for example, this is level T12, that means the nerve root of T12 is coming out from under the pedicle. Once again, the exception to this is the cervical spine, where the associated nerve root will exit superior to the pedicle, so it'll be the one above. So let's try another case here. So we have a 63-year-old male that presents to your office with a 2-day history of very severe low back pain and left leg numbness after shoveling snow from his doorsteps. And snow is pretty heavy. This is pretty common around here in New York, where we get some snow. But what's on our differential diagnosis here? So I see sciatica, herniated disc, spinal stenosis, disc herniation. Wonderful. So apart from this being a talk on the spine, what else could it be outside of the spine? Okay, wonderful. So I see muscle strain, kind of musculoskeletal. So I'm going to talk you through my thinking here, because my differential would also include muscle strain, but that's not very likely to cause left leg numbness. I also would be considering tumor, given that this patient is a little older at 63, and a tumor that's compressing the spinal cord can also lead to back pain and some left numbness, left leg numbness. But this happened right after shovel. Right, I see somebody said short history. It's acute process. Tumors are a lot more slower growing, so I would not be very suspicious of a tumor. I'd be most suspicious about some sort of herniated disc or direct acute spinal pathology. So we took some imaging, and it's shown on the right. Once again, I'll orient you. The patient here is facing to the left of the screen. The head is towards the top. The legs are down below. Quickly, can somebody remind me what kind of image this is? What modality we used? T2, wonderful. You see the CSF is bright, so that kind of keys us into T2 image, T2 MRI image. Now, in real life, when you take an image, you're not going to have these labels telling you which bone is which. I'm going to show you kind of the way that you can count it here. So we know that these last 5 bones are the sacral vertebrae, and they're fused in real life. On imaging, they kind of can sometimes have some spaces between them. The very first one of these 5 fused bones is the S1 vertebrae. The one right above that will be the L5. Then the L4, L3, L2, so on and so forth, and you could count that way. In this case, we see that there's this density that's arising from the disc space between L5 and S1 and kind of pushing or occluding the spinal cord partially. We call this a speed bump sign. Usually it looks a little more like a speed bump. This is a pretty severe case where the disc is herniating quite considerably into the spinal cord, but that's what you're kind of looking for. You're looking for some sort of disc bulging into the spinal cord space. So what's going on here? There's 2 parts to the disc itself. There's a nucleus pulposus in the middle, and surrounding it is kind of a thick fibrous layer called the annulus fibrosus. As we age, the integrity and strength of the annulus fibrosus degrades, such that any heavy or repetitive motions, including lifting, pushing, bending, or twisting, can cause this inside nucleus pulposus to push through and possibly irritate some of the nerve roots, and therefore causing pain and both motor and sensory symptoms. So what happens is this nucleus pulposus, it kind of pushes and impinges on this nerve root that's leaving the spinal cord. So I'll kind of also point out here that it's usually unlikely to push into the spinal cord itself because there's a very dense ligament. It's shown here called the posterior longitudinal ligament. So it's more unlikely to push into the spinal cord. It's more likely to push around the posterior longitudinal ligament and into the nerve roots that are exiting. So this is why you get a unilateral distribution of sensory and motor deficit rather than bilateral, but it is possible. So this is our patient. I think the same image that I gave on the last slide. This is a axial cut, kind of showing the herniated disc, the spinal cord, and the nerve roots leaving. You see that the nucleus pulposus kind of impinged on one of the nerve roots leaving from the L5, S1 region. And once again, so will an L5S1 disc herniation impact the L5 nerve root or S1 nerve root? And to help, I guess I'll go back a little here. So I see a lot of L5s. Wonderful. And why is that? No clue. Wonderful. So the nerve root starts or exits, especially in the lumbar and thoracic spinal cord, inferior to the vertebral body. So in our case here, we have the L5 and the S1. The L5 nerve root will be exiting inferior, and that will be the one that's getting impinged or impacted. So wonderful job. Okay, wonderful. So a very common procedure to treat I guess a herniated disc that's not significant, and once again you can grade this clinically as well as with imaging, is called a microdiscectomy, where a small hole is created. This is from the posterior side. Well, down here is the anterior and the spinal vertebral body, and the spinal cord are shown here. So we can access the spinal cord from the posterior side. And remove the part of the disc that's causing the pressure on the nerve roots and or the spinal cord. Unfortunately, patients typically do very well with this. The disc itself doesn't regenerate, but without the pressure on the nerves, the pain does subside. And a few weeks after, the patients may have to do some physical therapy or rehabilitation, but patients typically do very, very well. So in this case, 4 weeks post-op, the patient reports no more pain, there's no more numbness, and the patients return to full strength in both lower extremities. So this patient did wonderfully. Now, for this, there are several other treatment options for which you have to consider the extent of the herniation. You have to consider the patient's clinical picture, how they're doing, and whether they are optimal surgical candidates for a larger surgery. And you also have to consider whether they've had prior procedures at this level before. So that'll kind of, all three of those, as well as the imaging, will kind of dictate what approach you use. So somebody asks, do they just not have a disc afterwards? So that's not a stupid question. It's a fantastic question, and I think one that I asked when I saw this procedure for the first time. The goal is to not take out the entire disc here with a microdiscectomy. You're only taking out the portions that are causing the impingement or the pressure on the nerve or the nerve root. There are other procedures where the entire disc is taken out, in which case you may have to insert a spacer or some sort of artificial disc, or you could fix the two vertebral bodies together, which obviously would cause a little more stiffness, a little less range of motion, but those are all kind of different ways to go about this. Okay, so let's move right along because I think I'm running a little lower on time. So back to the case. From the imaging and the case, we have an L5 S1 herniated disc. Is it possible to tell or explain where the numbness is and which muscle groups are most affected? Wonderful. So somebody said dermatomes, and that's exactly where I was heading for this. So each nerve root subserves a specific region of skin as well as specific muscle groups, which are called dermatomes and myotomes, respectively. So here we have a clip of a dermatome map. along with some myotomal distributions. In our case, we have an L5-S1 disc herniation. We said that the L5 nerve root will be impacted. So we expect the numbness to be going down the back. I'm sorry, I think I should have made this a little bit bigger, but it's in green here. So we expect the nerve, the sensory impact to be down the back and the lateral side of the leg, anterior part of the shin, and medial part of the foot, because that's the L5 dermatome. And similarly, we expect that the same myotome will be impacted. So in this case, the L5 subserves the tibialis anterior, and this patient will likely have some issues with dorsiflexion, so moving the foot downwards. So somebody said can't stand on your toes. That's exactly how you test this. You ask the patient to stand, and they will be able to do it with one foot, but the other foot, they'll have some weakness, or they may not be able to do it completely, depending on the impact of the nerve root that the disc herniation has. So for any given spinal cord territory that's affected by some pathologic process, we could use dermatomes and myotomes to identify the specific region impacted. And this is a way that we can use our clinical history to go back and figure out what's going on with the anatomy. So this highlights why we really need to get a complete history and a good physical exam, and use that in conjunction with our imaging to kind of help, or best help, our patients. Okay, so next let's move away from the bones and towards the spinal cord. So this is a cross section of the spinal cord as it's running through the vertebral canal. Most of this structure is on the inside of the canal, but the nerve roots, as you saw, exit the canal itself. And some of this ramus, the dorsal and ventral, as well as this gray and white ramus and the mixed spinal nerve, these are on the outside bilaterally and immediately outside of the vertebral space and bodies. So this image doesn't do a great job because it only shows one. Know that there's two, one on each side. So there are, as you progress through your training, you'll get into more and more levels of detail with this. But for right now, let's discuss what gray matter and white matter are. So what is gray matter? Soma, neurons, cell bodies, wonderful. So gray matter is the cell bodies themselves, which make the white matter the axonal connections that are connecting to those cell bodies. So very crudely, there's a bunch of cell bodies in here within the middle part of the spinal cord. And on the outside, there's a bunch of white matter tracts that are used for both descending information coming from the brain, but also ascending information going back to the brain. And these follow some pretty intricate pathways. I think I have a slide on this, but that's for another day. We'll touch upon that later. But I do want to kind of emphasize the importance of the dorsal, lateral, and ventral horns of the gray matter. So let's start with the dorsal horn. What is the function or the key function of the dorsal horn? Sensory, wonderful. So sensory input from the body, including both somatic and visceral organs, will come and synapse on the dorsal horn. It's used primarily for sensing or sensory information, and will relay that back to the brain, predominantly back to the brain, I'll say. There's a lot of intricacies in here. What about the ventral horn? What's the function of the ventral horn? Motor. Great. So outgoing motor information will use the ventral horn, or the cell bodies that are in the ventral horn. And what about the lateral horn? What's the function of the lateral horn? I see sympathetic. Sympathetic, wonderful. So the sympathetic nervous system utilizes the lateral horn. And it's important to note that the lateral horn is most predominant in the thoracic and upper lumbar spinal cord levels, because this is where the sympathetic nervous system propagates before taking, once again, a variety of pathways to get to the target visceral structures. Wonderful. So this is a snapshot of the projections to and from the spinal cord. There are many pathways depending on what the organ is, whether it's a somatic versus autonomic organ. And there's many different relays that, once again, at some point, if you continue to be interested in this, you will learn all about. So as we get back to the spinal cord, I think I mentioned before that we need to kind of relay this information to the brain. So there's several ascending as well as descending tracts that communicate with the dorsal, ventral, and lateral horns. And once again, there are some very intricate pathways here. There's a very high level of specificity. I'll give you some examples. So the fasciculus gracilis, which is this section right here, will bring back light touch and sensory information from the lower extremities specifically. The fasciculus cuneatus to the lateral or laterally bilaterally on each side will be for light touch and sensory from the upper extremities. There's a lateral corticospinal tract. There's two of them actually, and those are also bilateral. Lateral corticospinal tract being for extremities, extremity movement, anterior corticospinal tract being for trunk muscles. And you can see that there's a ton of other tracts here. So there's very high level of specificity, and it's all for maintaining communication between the spinal cord and the brain, especially the spinal cord being the interface between the body and the brain. So lastly, let's talk about vasculature. The spine seems pretty important, so it's probably wise to have multiple and perhaps redundant blood supplies so we could attempt to avoid infarction or loss of blood supply as much as possible. So the spinal arteries, there's a few of them. There's an anterior spinal artery, which is running here. This comes off the vertebral artery. And there's two posterior spinal arteries that come off the posterior inferior cerebellar arteries. So that's depicted on the left, the one anterior spinal artery, the two posterior spinal arteries, and this is a view from the anterior side of the spinal cord. Now I know that this is a spine talk and cranial is next week, but I did have to include this kind of portion of the brain. I'm sorry for that. This kind of shows you the relationship between the pica and the posterior spinal arteries going down, as well as the anterior spinal artery coming off the vertebral artery. And there's a very intricate vasculature system. This right here is the pons and the medulla as it begins to form the spinal cord. So this is the skull base, and these two arteries kind of run longitudinally all the way down the spinal cord. So between the anterior spinal artery and the posterior spinal arteries, do you think this is enough to perfuse the entire spinal cord? It goes all the way down. No, wonderful. That's what I'm trying to get at. So there are several other redundant supplies, blood supplies, throughout the entire length of the spinal cord. There's segmental arteries that arise from each intercostal artery on some, if not most, levels. And those split into the anterior and posterior radicular arteries that supply or feed into the posterior spinal and anterior spinal arteries. And there are also several larger arteries that feed into the supply. One of the more important ones being the artery of Adamkowitz, which is around the level of T10. So this is all to kind of show you that there's a lot of redundant supply. Because the spinal cord is very important, we have to try to keep it as perfused as possible. And to do that, we have multiple sources of arterial supply. As well as a very intricate venous system that I won't show here. So let's do one more case. So in this case, we have a 58-year-old female with a long history of diabetes, type 2 diabetes, high cholesterol, high blood pressure, and 2 prior myocardial infarctions. This patient presents with a recently discovered abdominal aortic aneurysm. And I'll take you through this image here because this is once again, it's supposed to be a spinal talk, but kind of drifting further away here. This is supposed to be the descending aorta. You see that it is very, very large here. It's much larger than it should be. And to fix this or to repair this, we did open surgery to repair the aneurysm. So immediately postoperatively, you find that she's unable to move her legs, and there's complete loss of pain and temperature sensation bilaterally from the mid-abdomen below. What do you think has happened? Nerve damage, spinal arteries cut off, ischemia, all in the correct direction. So very briefly, to kind of approach this, we take an anterior approach rather than a posterior approach usually. That way we could spare the spinal cord as well as the vertebrae, and the approach from the anterior aspect is a lot more straightforward overall in most cases. So we don't actually cut the nerves themselves, but some people are saying ischemia. That's kind of where I'm trying to get at. So around the level of T10, I mentioned that there's an artery of Adamkiewicz. It's very likely in this case that this specific artery was damaged, causing spinal cord ischemia and potential infarction. So in cases like this, abdominal aortic aneurysms are very likely to cause involvement, if not damage, of the artery of Adamkiewicz. And since it's a very key supply to both the anterior and the posterior spinal arteries, you're sometimes going to get gross motor deficit and sensory loss below this level. And the constellation of symptoms that you see clinically is on the right here. Okay, so that was fantastic. I'd like to wrap up with a quick question. If you wanted a longer neck, would you A, increase the number of vertebrae you have, or B, elongate each individual vertebrae? A lot of B supporters. Okay. So you could end up doing either. So for example, a giraffe has longer individual vertebrae, so the vertebral bodies are longer themselves. But evolutionarily, there have been some creatures that have increased the number of vertebrae in their neck. So there's just a lot more, but the height of the vertebral bodies was overall preserved. So pretty interesting. And I think that's a pretty interesting tie-in. So thank you, everyone, for joining in. Thank you for your active participation. I think it's a wonderful audience, and I love when I'm able to interact or interface with the people listening. I think I have a few minutes, maybe 5 or 6 minutes for some questions, and I'm happy to take those. Let's do in the Q&A. Whatever I don't get to, I'll kind of stick around and continue typing in. My contact information is here on the bottom right. I've included my email. If you're more of a Twitter person, I have also included my Twitter, which I've made recently. And I'll take a few questions now.
Thank you so much, Akash. That was an amazing talk. So first question that we have is, if part of the sacrum is removed, does it automatically mean that the individual has no use of their legs?
So that's a good question, actually. And there are not many clinical scenarios where fortunately we have to do this, as in remove the sacrum completely. But if you do take out the nerve roots of the sacrum, it is true that you would lose all function that those nerve roots supply. So that includes motor function. It also includes bowel and bladder function as well. And this also holds true for any level. If you take out that nerve root, the distribution of that nerve root that it's applied, both sensory and motor, will be impaired. Good question.
Next question. What goes on during embryonic development that causes these vertebrae to vary in features?
That is also a very good question. And honestly, I don't know if I have a great answer for it. I know that each of these vertebral bodies, each bone, inside as well as outside the spine, there is a basis for it evolutionarily. And they've just kind of developed in this manner so that the function matches the form of the structure that is being evolved. I don't know if that question that's a good answer, but
no, that's a tough one. Are there any factors which would lead you to perform a fusion in this case? So I believe I was referring to, yes, maybe the disc herniation.
the disc herniation, yeah. So there are some factors. There's a very intricate workup that goes in. Once again, you look at the imaging, you look at the physical exam, you look at the clinical picture of the patient, what their symptoms are, and whether they're good surgical candidates or what they'd be a good surgical candidate for. I would say that if you can get away with a more minimally invasive or less a more minimally invasive procedure that has less of an impact on the overall anatomy and structure, you probably want to try to do that rather than go in and do a larger procedure that may have the same outcomes. I think that the decision whether to do one or the other is very difficult and one that you kind of gain experience with in your career, and you just keep getting better at it as you keep doing them.
Another question in regards to disc herniation. So when the annulus pulpus is displaced, how do you fix that during surgery? What do you do to actually address that?
Sure, let me skip down to those slides here. So when you do a disc herniation repair, this is all tissue. So you can physically go ahead and grab this tissue and remove it. And it's kind of like this jelly fibrous blend that you end up pulling out. And you could physically remove some of it without taking out all of it. I know that's kind of difficult to maybe wrap your brain around, but when you do see it and the pieces start coming out and you feel one of these, you'll kind of get the idea of what you're taking out and why you're taking it out.
This is a non-clinical question. How do you, as a continuing med student and you're pursuing your PhD now, how do you avoid burnout and take care of yourself?
That's a fantastic question. And honestly, one that at the start of my medical school, I didn't really think about until it started to impact me. It's very important to just have outlets, whether that's writing or like sports or going on a walk or whatever that might be for you, to kind of let loose and do something that you have an interest in. That's extremely important in most, if not all, stages of your education and career. For me, I love playing sports. I love basketball and I play baseball as well. So that's kind of my outlet. And then I also like to write as well when, the New York weather is not very, giving towards outdoor sports.
Amazing. I think we have time for one more question. These are also great. Would you like to choose one?
Sure. In the Q&A, I will share the slides. I think we can send those out. Let's go over the signals a little bit. Going up and down the spinal cord. I think I very briefly touched upon this, and this once again in medical school was weeks worth of content and lectures. So these ascending and descending tracts, they are very intricate, and there are many different fibers that go up and down, and there's several pathologies that occur as a result. Some of these tracks do cross over at this point. Some of them cross over at a higher point. At this very point, everything that the spinal cord is subserving is largely ipsilateral, as in the same side. By the time it gets to the brain, it'll be the contralateral side. So that's why, for example, the left brain controls the right arm movement, and the right brain controls the left arm movement. So these signals do cross. Where they cross differs. That's a good question as well.
Fantastic. Well, thank you again, Akash. It was so nice hearing from you, and thank you for condensing all of this material into 1 hour. I know it's you covered so much, so we really appreciate you and your expertise, and wish you the best of luck as you continue to pursue your degrees.
Thank you so much. And if anybody has any questions, I dropped my email, and it'll also be in the slides, but please feel free to reach out. And thank you so much, everyone.
Thank you again. And I just wanted to address a few questions that I received about shadowing at Lenox Hill. So as much as we would love to accommodate everybody to shadow our team at Lenox Hill, we just received some new restrictions on the students that we are able to accommodate. So we, unfortunately, we would love to have everybody come and join us in person in the clinic. We, moving forward for shadowing opportunities for inpatient and ambulatory settings, will be able to accommodate that experience for the following individuals: students who are scheduled for clinical or administrative rotation via their an educational program that's affiliated with Northwell Health. And it may only occur during your scheduled rotation date range. Students completing their clinical rounds as required in pursuant of their curriculum. Students seeking to enroll in healthcare professional training that has an affirmative observation requirement as necessary component of the application, and proof the requirement is provided to us. So if you're not required to shadow for your program, we're no longer able to allow informal episodic shadowing requests for high school, college, or medical students, team member relatives, friends, neighbors, and individuals observing without being a part of an affiliated educational or formal volunteer program. I'm going to post all of this in the chat so that you can see it. If you're seeking exposure to the hospital or clinical operations and you don't have a requirement for an academic program that you're participating in, we encourage you to take advantage of Northwell Health's pipeline programs like BRAINterns and other programs that we offer, or to become a Northwell Health volunteer and to volunteer at the hospital. So unfortunately, I know we would love for you all to come and do TikToks with Langer. That would be awesome. Oh, why isn't it letting me paste this? This is super annoying. Let me, one more time, shadowing, copy. Okay, let's see. Well, let me paste this to everyone. Oh boy, it's not letting me paste it. But basically, if you don't have a requirement, unfortunately, we can't facilitate that shadowing opportunity. So if you are interested in shadowing us and you do have a requirement for your program, you can email us at lhhneurosurgeryeducation@northwell.edu. Again, that's lhhneurosurgeryeducation@northwell.edu. I know, no, and I know it's, it's a blessing and a curse. We've received so many shadowing requests that we've had to kind of crack down on who we're allowed to have come into the hospital through our Department of Volunteers. It's not even our department, it's the hospital. And we're really grateful that we've been able to facilitate these shadowing opportunities. So again, if you're interested in just getting more clinical exposure, you can volunteer to join us at the hospital as a volunteer. And just in doing that, not only will that be great community service that you can put on your CV for med school or residency, but you're able to get some exposure to what it's like to work in a hospital setting. All right. Quinn, would you mind reposting the Facebook group link?
Of course, I'm doing that right now
Perfect.
in the chat.
Volunteers can be high schoolers. Yes, you would need a parent's consent in order to volunteer. And in terms of jobs, you can always go to our Northwell. I can post the website in the chat. Northwell. There's like a job, Northwell careers. Here we go. So it's jobs.northwell.edu. If you're interested in working for Lenox Hill Hospital, this is where you can find openings and where you can apply. Oh, look who just joined us from the OR. I see Dr. Randy D'Amico.
Hey guys, how you
Incognito.
doing? Listen, I need about 20 minutes. How is everyone doing? How was the first lecture? Did it go all right?
Let's go, Randy. Cool, great,
Great. I love it.
wonderful,
All right.
amazing.
Yeah, exactly. So I'm gonna be, I need about 15, 20 more minutes, and I apologize, it's just a busy day. And then I'm gonna be able to sign in and give you guys the first lecture. So that's fantastic. I'm glad you guys are all chatting. Go get some coffee and I'll be there soon. All right?
All right, so everyone, we will resume at 11:25 a.m.
Be back.
And again, if you would like to access the schedule, it has been posted on the BRAINterns website under registration and 2023 schedule. I'll post that link right here. One more time. All right. I have too many tabs. Oh boy, oh boy. You all, Quinn's like, you're so tech savvy. You're seeing that I'm not. But
She is really tech savvy, I promise.
but amazing. So thank you so much, Akash. It was wonderful hearing from you. Thank you again, everyone. His email is in the chat. It's amishra4@northwell.edu, and we will see you at 11:25.